Welcome back this morning. It's great to see you all again. I hope you had a great evening in San Antonio. There's so much to do here, great restaurants, great things to do. So I hope you enjoyed the evening. And I know you're in for a real treat today, so for the rest of the colloquium. And we're excited about the presentations for today. The American Institute of Dental Public Health is governed by a board of directors. We have a very distinguished group of board of directors. I'd like to take this opportunity to just thank them and recognize them today for their work. Caswell Evans, Raul Garcia, Jeffrey Chaffin, Steve Geierman, Joshua Houston, and one of them couldn't be with us today, Andrea Height. Please join me in thanking them for the help that they provide for this organization. Now I just have a couple of housekeeping issues to go over with you. So we provide continuing education credit or CE credit for this program. In your packet, in your folder, you have two forms. One is an evaluation form and the other is the CE form. Both of them have to be returned if you want CE credit. So we're going to ask you to return them both. There are bins downstairs on the registration desk. So please, if you want continuing education credit, please fill these out and place them in the box on your way out today. We appreciate that. We also appreciate your feedback. So on the evaluation form, please let us know what you thought was great and what you thought could be improved. I will assure you that we read those, we take those seriously, and we modify the program based on your input. So thank you very much for that. The idea of the colloquium was really to discuss a cutting edge or novel idea in dental public health and to bring seasoned scholars along with students and residents together in one venue to discuss that topic. I want to challenge the students today, the students and the residents who are here. I encourage you to sort of step out of your comfort zone a little bit. You have a great opportunity here to sit down and talk with mentors and people who could be mentors for you along your career path. So I encourage you, if you're a young professional or a student or a resident, to seek out some folks who have been in your career path where you're going to be going a little longer and talk to them. The idea of the colloquium is really to develop the future of dental public health. And the students and residents in the room and the young practitioners are the future of dental public health. We're excited that you're here, and we hope that this has been a rewarding conference for you. So with that, I'm going to go ahead and introduce our first speaker, and this is going to be a treat for all of us. The first speaker for today is Dr. Lois Cohen. And truly, Dr. Cohen needs no introduction, but she's going to get one anyway. Dr. Cohen, as most of you probably already know, has had such a distinguished career in global oral health. She is a consultant and a Paul G. Rogers Ambassador for Global Health Research. Dr. Cohen served as the Director of Extramural Research, the Associate Director for International Health, and the Director of the World Health Organization Collaborating Center for Dental and Craniofacial Research at NIDCR at NIH. And NIDCR is the National Institute for Dental and Craniofacial Research at the National Institutes of Health. After retiring in 2006, but believe me, none of us believe she really ever retired. She retired from 2006 from federal service. She's remained as busy as ever as a consultant to National Institutes of Health, the World Health Organization, Canadian Institutes for Health Research, as well as other organizations both nationally and across the globe. Dr. Cohen's presentation is Confronting Inequity Through Global Health Policies. Please join me in welcoming Dr. Lois Cohen to the podium.
Thank you. Thank you, Dr. Capelli, and the entire American Institute of Dental Public Health. This has been a wonderful meeting for me. It's the first time I've been with you, and I've learned a lot just by sitting and listening all day yesterday. So I hope I can add a little different perspective to the wonderful material that we've been exposed to on reducing global inequities. The perspective, of course, is a global one. Now, for those who don't know much about me, I'm not a dentist. I'm a PhD sociologist. I was recruited to the US government intentionally. There was a social studies branch in an old division of dental public health and resources, it was called, in a now defunct Bureau of State Services, which preceded a Bureau of Health Manpower, which went into the Health Resources Administration, which then got merged with the Health Services Administration, and today is HRSA. That's from 1964 to the present day, and how government changes and how what we do changes. Anyway, we had a social studies branch, and I was recruited as one of the sociologists, and there were psychologists, economists, medical anthropology, political science, all brought together to look at oral health issues of the time. And the involvement was not global initially, it was national. And we had given grants to state health departments throughout the country to have dentists examine for oral cancer, early detection of oral cancer. It was a real challenge because dentists were not taught about soft tissue in those days, believe it or not. And so they needed social scientists actually to figure out how to get dentists to look at soft tissue when they weren't trained to look at soft tissue. But that's a whole nother story. But the point I'm making is that the issues were national and local, very much focused on issues important to the US government and to the states and local health authorities. So what brought me into the global health picture and how I had global health in my portfolio, even though I had responsibilities nationally. I had global health officially on my portfolios probably since the late 60s, early 70s. Anyway, moving right along, I want to start at a very simple level, just so we're on the same page. In 1948, the World Health Organization was established along with the United Nations post-World War II as a major health arm. And when they were set up in 1948, the same year the National Institute of Dental Research was set up, the same year the National Health Service of the United Kingdom was set up. Post-World War II, we had to deal with the disarray of the infrastructure throughout the world. So this is the definition WHO came up with, and I like this definition of health. As a social scientist, I like it because it doesn't just focus on physical and biological health, but it addresses mental and social well-being. And when you talk policy, you find out that mental and social well-being became more important metrics for policymakers than the physical health. Just think about what we count as physical health and oral health. Holes in the teeth, debris and calculus in the mouth. You think a policymaker cares about that? No, they really care about our mental and social well-being, whether we can go to school, whether we can get jobs, whether we contribute to economic and social development, whether we impact our society in terms of productivity. So this is an important definition. I like to start with that. And moving along to what is global health. There are many definitions of global health. By the way, I just remembered something. The FDI, International Dental Federation, is the organization of organized dentistry, the organization that brings national dental associations together. They took this health definition that I just talked about and revisited it in terms of oral health. So they did one thing better, since they had a long hiatus since 1948 in looking at it. They could look at all the research that was done around the metrics of health and measurement. So I recommend that article. I think Michael Glick was the lead author, and it's in the International Dental Journal. By the way, I do have suggested readings attached to my material, which should have been posted on the website. So let's move on to global health. What do I mean here? There are many definitions, and they're very controversial. Some people define global health as anything we do to the other country. That's global health. When you send a mission out to a low-resource place in this hemisphere or Africa or Southeast Asia, they call that global health. That isn't necessarily what I call global health, and which many others call. I happen to like this particular definition developed by the Institute of Medicine of the National Academy of Sciences in the 90s, when they had to come up with a US commitment for global health. They have since revised it a couple of times in their later publications, but this original definition sort of resonates with the way I feel about it, that it's really the area, the space in which health transcends national borders. And it's just not that the health issue crosses borders, and those issues are influenced by experience in other countries, but importantly, the solutions are best approached by cooperative or collaborative action. To me, that's what global health is about. It's not the North, highly industrialized country, going to the South, a very low resource country, and giving what we know in the West to the poor people who don't have resources. We're in the North and they're in the South. And we talk about North-South relationships. That's not what it's about. It's about finding solutions together. The idea of reciprocal learning. We have a lot to learn from the least resourced countries in the world. We can find some low-cost, simple interventions that can replace often our highly complex, expensive interventions that we used in the highly industrialized North. So it's not just North-South reciprocal learning, but South-South and North-North reciprocal learning. The solutions we gather by coming together and doing it together. So that's what my view of global health. So what do I mean by global oral health? The very same things. And the WHO does have an oral health officer sitting in headquarters in Geneva. We were very, very lucky in the early days. The National Institute of Dental Research helped the World Health Organization establish an oral health presence by collecting epidemiological and surveillance data from around the world, developing guidelines of how to do it. So we had epidemiologists in the Dental Institute in the early days, Al Russell, John Knudsen, and they went to the World Health Organization and helped them set up an oral health presence. So we were there from the very beginning. From time to time, the presence of oral health has been threatened with all the budget cutbacks, and we've really had to come together globally to bring our resources together to argue to the Director General of the WHO why we needed to retain oral health. And believe me, we still face these problems regularly. But right now we have an oral health officer there, a French national by the name of Benoit Varenne. You can go online and there is an oral health page. They're in the business of updating it right now. But data like this is, the fact sheets are on the page, and it's a very good resource. Now, WHO has 2 affiliate organizations that any of the vertical programs within WHO is allowed certain affiliated organizations. The 2 which are in formal affiliation with oral health are the International Dental Federation, the FDI, established in 1900, and the IADR, the International Association of Dental Research, which celebrates its 100th anniversary in March, are the 2 affiliated arms that work in concert with WHO. So the FDI has organized dentistry has really stepped up what it's doing in public health too, and started collecting, being a reservoir of these data and helping WHO populate this, and so has IADR. And we'll get into that in a little while. But some of the data that you see on this slide come from a variety of sources, from the Global Burden of Disease Study, which is an effort out of the University of Washington in Seattle, funded by the Gates Foundation. They look at all diseases of the world and look at the global burden. And the oral burden is included in there and is included in the reference list that we have posted. So we have the data on what we think is the estimated burden for dental caries, 3.5 billion dental caries prevalence. Most prevalent of all of the non-communicable or chronic diseases. I rather like chronic better than non-communicable, but the nomenclature these days is non-communicable. Severe periodontal disease is thought to be the 11th most prevalent. And the International Agency for Research on Cancer in 2018 felt that oral cancer is in the top 3 of all cancers, particularly in the Asian Pacific countries. Oral dental trauma, 20% of all traumas worldwide. Congenital anomalies, again, more prevalent in certain parts of the world and then in others. And it's very important to know where the most prevalent in terms of you're doing research on cleft lip and palate, for example, as NIDR and the National Institute of Child Health and Human Development has supported Jeff Murray and his team at the University of Iowa for doing this kind of research. They went to the Philippines to do this because it's one of the highest prevalence of cleft lip and palate. He can sit there in Iowa, see 50 cases a year. In the Philippines, he can see 500 cases a week. You know, it's a difference of in magnitude. Now, how many people have ever heard of NOMA? Anybody ever seen NOMA? NOMA was a condition, or is a condition, that is in certain parts of sub-Saharan Africa. There is a hospital just for NOMA in Sokoto, Nigeria. NOMA was actually seen in the concentration camps of Europe. When you study NOMA, apparently, it is a disease of poverty, of poor sanitation, poor housing, social determinants of illness, living with animals, problems with water. And children who get this, it's often children, it's called oral gangrene of the face, and it can eat away at the face and kill. So, Ellie, some dental diseases do kill. NOMA is a case of, and we know caries also can kill. Diamante Driver died of dental decay that went to the brain. And so Elijah Cummings could then step up, and it was in his district, can do something. So dental disease can kill. Anyway, NOMA does kill, and there is a big initiative for NOMA in Africa, and WHO Regional Office in Brazzaville has the responsibility for NOMA and dealing with it. We had hearings in Congress on it several years ago, and the ambassadors from Niger and Nigeria, and I forgot which other country, testified, and our researcher at the time, Cyril Nwanwu, highly regarded, knowledgeable about this disease. We had to make testimony before Congress because it was deemed a human rights issue if we didn't deal with it. So we have some life-death issues. I won't go through this. You sort of have seen this yesterday, but it is a global issue that I will raise. You know, when we talk about global health policies, the UN passed a major policy in 2011, September 19th, 2011, I won't forget it. It's the first time oral health appears in the language of the United Nations proclamations. It was a proclamation on the prevention and control of non-communicable diseases. They defined the 4 major non-communicable diseases as heart disease, cancer, diabetes, and respiratory diseases. But they had Article 19 included that we worked very hard on talking to include oral, renal, and eye diseases. And then later on, the mental health constituency added mental health at a later point. But this is the first time oral diseases appear in any official documentation like this of the United Nations. And that's one of the policies I will go through. So the 4 diseases are listed up there as non-communicable, and you will see how oral, we use this kind of schematic to argue with the policymakers who are drafting the language of why we share the same common risk factors. Diet, unhealthy diet, sugar, substance abuse, alcohol, drug abuse, and poor hygiene, lack of physical exercise, etc. We drew these lines to show we have the same risk factors. Now, this schematic is very interesting because this is what I was driving at in terms of policymakers. What do they care about? This schematic was used for the National Health Service when they were refining what they should do about covering oral disease. When I first got into this business, National Health Service covered most of the cost of oral care in the UK. and then quickly started having budget problems. So they kept cutting back, and they then cut back to 50% of the costs. So the argument of why you have to deal with this disease was the reason for this schematic, and looking at the impact. So it's not only individual impact, as evidenced by social isolation, the cost of individual treatment, aesthetics when we talk about social mental well-being, but it has to do with poor educational performance, reduced productivity in the workforce. The cost of getting care takes you away from the workforce and how you get there, etc. And this really talks about all the functional limitations if you do not have oral health. It's very useful to look at, especially when you're trying to develop a measure for this. So I talked a little bit already about how WHO responds when the United Nations makes a declaration like the Declaration on Non-Communicable Diseases. WHO is then given the marching orders to go carry them out. And each member state of WHO votes. And so even though the United States might not be the first one to take action on some of these things, very often it's not, unfortunately. But other countries take this seriously and line up their priorities accordingly. And when you think of the very low resource countries, they were hit by communicable diseases first, but now they have a double burden. As they conquer the infectious diseases, they have the double burden of the chronic diseases on top of it, and yet they have very little infrastructure. We talk about our diminished infrastructure. Some of them have no infrastructure at all. And so this, plus the double burden, is almost an impossible thing to think about. But we have to think about it. We talk about policies, and I wanted to say that even though we think of local policies, state government, national policies, and then global policies, even the global agencies have to think of policy at multiple levels. Policy that address individual behavior, group, family behavior, school behavior, institutional behavior, food policy behavior, trade policy behavior, all the infrastructures of the social determinant, housing, education, everything that relates to social determinants, also global policy has to address those. They don't set the policy, but WHO is what's considered normative organization. They set the norms. They set the standards. They help countries. They don't dictate to countries. They provide norms which allow for guidelines to be developed, and then they make guidelines available to all member states. There are 193 member states. And then those member states can take it or leave it or pick and choose what they think is appropriate for them. So I wanted to also quickly review something about health policy that we all have to think about at whatever level we're dealing with. We deal with the evidence base, the data, and I still go to work at NIH, so we work on research, and so that's the evidence base. But we all know that in order to get policy enacted, we heard that beautifully represented yesterday, especially in the panel on disabilities, the political action that's necessary to get policy enacted. And that won't work unless you have all those letter writing activities and all the social will, that social movement of people who are impacted. Those people have to influence the policymakers who then can use the evidence to make it happen. So those are the main buckets of information. Now, breaking it further down, the kind of data is not so simple either. At NIH, we have focused on biomedical data. It says in our mission we're supposed to do biomedical and behavioral. But let me tell you, we do mostly biomedical. Most of you know that already. We leave it to other agencies to pick up health services research and other kinds of research. But it all ties together. You need it all to come together. And that's been my frustration as a social scientist working in that environment. I was brought over from this Bureau of State Services in 1976 to the then National Institute of Dental Research. And they had to bring me before the National Advisory Council. Why do we need a social scientist here? You know, they had the council had to affirm that we needed behavioral and social sciences in the Dental Institute. But Dave Scott, who was then director at the time, was very persuasive, and he got behavioral implanted into our institute. So it is in our portfolio, it's in our mission, and we have lots of grants in this area. But we also have to break down what is social and environment and what is behavioral. So we all know what research examples are going on now from the research on the oral microbiome and how sugar and other nutrients, bacteria, figure into this. But regenerative medicine, look, the United Nations Environmental Program, how many people know about the Minamata Convention? You know that, yeah, good. They want to phase out, ban all mercury in the environment. So in terms of the dental part, which is in amalgam, they have agreed after a lot of lobbying and a lot of work on the part of the IADR, the WHO, and the FDI, and a lot of consultants in restorative materials, to phase down, not ban it. But it's going to be phased down, and this is part of WHO's 2020 agenda. They have a 3-year plan to get countries still using amalgam onto something else, and they have to do it by preventing the disease in the first place. That's the first thing. But regenerative medicine is terribly important. We used to think that enamel was the only part of the human anatomy that couldn't regenerate, but we know that's not so anymore. So new materials, they won't have the long history of that amalgam has, research history and evidence, but we have to come up with new materials pronto, because dental amalgam will be off the table. New vaccines, HPV, refined vaccines, gene editing, and we do this, we have research through the salivary gland that has been pioneering research, cancer and immunotherapy, pain management, and of course, we've talked about personalized care and precision medicine. How about social and environmental research? International Association of Dental Research has the IADR GOHERA plan. That's the Global Oral Health Research Inequalities Research Agenda. They call it GOHERA. They did this in 2012. I think I have a slide on it. It looks like this in the Journal of Dental Research. But anyway, that maps it out. It has to be updated all the time. It's always out of date and needs specification. But IADR has stepped up to the plate. They have a GOHERA network of researchers that cuts across the vertical groups of the association, so people can come together and talk about what they need in this area to reduce global inequalities. But things like predictive modeling for innovative workforce modeling. There is just a call this past week, I got on email, a call for papers on oral health workforce modeling, that it's due at the end of December 2020, to rethink globally. And there are lots of different examples all over the world and what is the evidence of effectiveness for different workforce modeling. Also, how do you communicate science? Science is coming out so quickly now. How do you communicate it not only to the practitioners, but to the public? And one thing I learned from that very first project I was recruited for on early detection of cancer for dentists, how do you make dentists change their behavior? By exerting patient pressure. The patients come in and ask for it. That was one of the major findings. And we learned that it wasn't our own invention. We learned that from the Pap smear. How did physicians face the same thing? They didn't want to do the Pap smear on women. So American Cancer Society advertised on television, on radio, and everywhere, women go ask for it. And then the utilization rate went up. So we tried it. We did some experiments on the early detection of oral cancer. And that was one push. So it's not the total answer, but it certainly was helpful. So communicating science and dissemination of innovations, terribly important area, as the results of science are just mushrooming and coming out so fast you can't keep up with it. And then when we talked about impact, how do you measure it? And there's been great progress from the early work on sociodental indicators to oral health-related quality of life metrics, oral health impact performance measures. There are lots of them out there, but we have to refine them and get them used and communicate them effectively. So that's what OHRQ of L means, oral health-related quality of life. It's my shorthand. And then I give the example of the study that got me into global in the first place, that moved me from a national problem to a global look for solutions. And that's the International Collaborative Studies 1 and 2. Now, how many people know about these studies? I know Ellie does, and Cass. The US government was talking about national health insurance for a long time, ever since I was there and before, when I came in 1964, but before that also. When I came, the president was Lyndon Johnson, and he had a great society, and he was very interested in healthcare. It was the start of neighborhood health centers and Head Start. Then we had President Nixon, and I was a young research sociologist, and he had opened up China, our relationship with China, to the world, and global was okay. You could now do research outside the country. Believe it or not, it was almost impossible to do it before that. But he also had a proposal for national health insurance. It was a proposal that simulated what Japan had. Japan was a culture where people worked for a lifetime for large companies, and the large companies covered them for health and other social insurance. So half the population was covered, for oral health included, under that kind of employer benefit scheme. And the other half that didn't work for those companies were covered by a government health insurance, sort of like a Medicare kind, but for the total population. And President Nixon proposed that. Ted Kennedy had a proposal. It was much like the UK health plan. And other people had different kinds of proposals. So here we are sitting in the Division of Dental Public Health and Resources and Bureau of Health Manpower and saying, what are we going to propose for oral? Because we only have private practice fee-for-service. So that's what we had. We had so little insurance in 1965, 66. Hardly any. We had one person assigned to cover insurance, I remember. That was it. So that prompted us to have to go out of the country. You have to look outside your borders. If you don't have models inside, you have to look out. Now, we had the beginnings of neighborhood health centers. We had the beginning of Head Start by then, but just the beginning, little bits and pieces, and no long history. So we went to our chief dental officer and made the case. Our chief dental officer was John Green. And he said, well, he liked the idea. And we had to go find a way of doing this. This was the Cold War, by the way, with Russia, who was sitting at the oral health unit at WHO, but a Russian officer, Vladimir Rutko. So how was this going to happen? So John Green met Vladimir. Normally he met him at the FDI once a year. He went to the World Dental Congress. And he raised it informally. And Vladimir liked the idea. Now, when you walk into WHO, you drop your political identity, your national identity. You're not supposed to have any of these political antagonisms or introduce that into your work. And he did, both of them did that. They said, yeah, let's think about this and let's use WHO as the neutral platform. We'll bring countries together through this neutral platform, and we're going to devise a common protocol to collect data in a number of different systems, oral health care. We called them dental manpower systems. You know how the nomenclature is now changed. We talk about human resources. We don't talk about manpower. But the original name of that study was the USPHS WHO International Collaborative Study of Dental Manpower Systems in Relation to Oral Health Status. So you can see why we changed it to ICS 1 and 2. We also had to get rid of manpower. We didn't want to use that anymore. And we found out soon enough it wasn't all about workforce anyway. It was about systems. And we heard yesterday the good description from our workforce specialist that it really is larger than the workforce. It's how they're embedded, the context of the total system. So we did that, and I'll make a long story short. We did 2 of these studies, and they're both published. And let me see if I can jump ahead. Oh, there, whoops. There it is. The first one is Oral Health Care Systems, published by WHO, a monograph of 10 countries, all the way from private practice fee-for-service systems like ourselves and the area of Australia, New South Wales on one end, all the way to the Eastern European models that were polyclinics, which were just large neighborhood health centers, government salaried health providers providing services, and all under one roof, nice integrated care under one roof. That was the Eastern European model. And in between, we had various different variations. The New Zealand model remember, New Zealand has had 2-year trained post-high school, girls trained, no boys, all girls trained to do dentistry in every single school in New Zealand for children up to the teenage years. From adolescence, they had gone to private practitioners but reimbursed by the government, and then nothing for adults. The adults were left to the private system. But children were covered. That started during World War I because people couldn't bite the bullet. Soldiers, not people. Soldiers couldn't bite the bullet. The solution, put a dental clinic in every school in New Zealand, North and South Islands of New Zealand. So that was a very old system. It wasn't the oldest system. The oldest system was in Germany, West Germany, from Bismarck's time. That's where many social insurance funds, as many as 2,000 social insurance funds exist. Every 97% of the population, all but the most wealthy, don't have to join that, but they all can be covered through the social insurance system. So through the West Germany was in our system. We actually had East Germany also in our study, thanks to Vladimir Rutko, and we had Poland in the study as well as for examples of East Europe. We had Scandinavian countries represented by Norway, where children were covered in a clinic situation by salaried dentists, not auxiliaries, salaried dentists, and nothing for adults. Again, private practice for adults. And other variations. So the second study was done 15 years later to see what happened, and the Indian Health Service decided they're a separate country. They've said, we're going to come into this study too. We want to learn how to do this better. What was the idea of the study? We wanted to look at the structural features of these systems in order to look at the outcomes. And the outcomes were a ratio of services provided to population need. These are the original countries. The hypotheses were the more available, accessible, and acceptable the dental care provided to the public, the more positive effect is on the population's oral health. Availability measures these are just some examples, they're not the only ones. Accessibility measures, not the only ones, just the main ones. Acceptability measures. And on the bottom of this slide, look at the ratio of services to need. When you do comparative studies across countries, you can't do absolute numbers because everybody starts out with a different level of need. So you assume that the service provided, the system in place, is there to meet the needs of its population. So you don't use an absolute number comparison. You do the ratio. And that's why the service over need is so important to remember. Do the services meet the needs of that population? These are just a schematic, and you'll be able to look online at this example of some of the structural features and the sampling areas that we looked at. We took samples we had a standard protocol for the framework and the sampling frame, and we had an urban sample and a non-metropolitan sample in every country, and not the capital of the country, because we assumed all the good resources went into the capital. We did not use the capitals on purpose, so we used another urban center and its rural or non-metropolitan counterpart. So let's go back. You can ask me about the results of the study and its impact on the various countries, but let's go back to global health policies for a minute. I'm going to jump ahead from the 60s and 70s and 80s when we did the ICS-2 studies, And when we set up, by the way, collaborating center at NIH, there are now, I believe, 12 WHO collaborating centers around the world for oral health. We are not one of them anymore. We were for about 20 years. The only one in the United States is at NYU. Where's Richard Niederman? Oh, there he is. He's under a hoodie. Meet the director of the only US WHO collaborating center right now is at NYU. It's been extremely helpful in some of these policies on this slide. Well, the first two policies, there was no center at that time, and we weren't directly involved. But I mention them because UN, I'm going to rush through this, and I'll stop when you tell me to stop, because I have too much material here. But the UN set up the Millennium Development Goals. And some of you may have heard about them. The important thing to remember about the Millennium Development Goals set up in 2000, expired in 2015, was they were very important for making health central to economic and social development as viewed by the United Nations. Put health at the center. You can't have economic and social development without health. There were a lot of things wrong with the Millennium Development Goals. I do have some slides on it. Oops, here it is. This slide in particular, when you have a chance to examine it, will have the strengths of Millennium Development Goals, but also its weaknesses. Its weaknesses that it was built on siloed vertical programming, and that is non-functional. So they were replaced more recently in 2015 by the Sustainable Development Goals, the SDGs, and they're horizontally integrated. So health is a goal. It's Sustainable Development Goal 3, but it's integrated with education and housing and clean water and environment, etc., in a much more integrated way. So I won't go into the details, but the resources are there. Now, in 2001, the UN had its proclamation on HIV/AIDS. Very important. First time the UN ever addressed health, other than putting health into the middle of the Millennium Development Goals in a proclamation. And the UN AIDS program was born then. PEPFAR grew out of that development too, the US response. In 2008 was the WHO Landmark Commission on Social Determinants, and now everybody talks about social determinants. Michael Marmot was chair of that commission, a physician at University College London, and note that Aubrey Shyam and Richard Watt and that team are in Michael Marmot's department. And I'll bring that up in a few minutes, why that's so, so important. In 2011, I mentioned September 19th, and this is where NYU has been extremely helpful, held a side event at the UN General Assembly meeting, putting teeth into the NCDs, it was called, and argued with the help of the president of Tanzania and his ambassador to the UN mission, helped organize all the developing countries to make oral health important, had all the 52 developing countries out of 193 member states signed on to this, and then brought everybody along. Nobody could argue that oral health had to be included. And then 2015, the Sustainable Development Goals, in which health is still there. And most recently, this past fall, the United Nations did it again. They had a proclamation and declaration for universal health coverage. And through a lot of effort of the FDI, the IADR, and everybody related to the WHO and the collaborating centers and NYU in particular, we thank you for another side event which reaffirmed that oral health was in the final language of this Declaration for Universal Health Coverage. Now, these are important steps and they guide WHO today. This, for example, is the guidelines that WHO provided for Africa to promote oral health in Africa as a result of the Declaration on Non-Communicable Diseases. This is the strategy plan. Sustainable Development Goals. U.S. Not doing so well as we could have predicted. Now I'm going to get to what just happened. The UN high-level meeting on universal health coverage and the oral health side event, which I mentioned, leaving no one behind. Note that just prior to that meeting, which was in September, right? I got to look at the date. Can't remember. September? In July, I'm going to go back just a couple months. July 21st, 2019, the Lancet journal came out with an oral health series. First time the Lancet recognizes oral health. Its editor-in-chief, Richard Horton, at the launch, there was an official launch at the University College London on July 24th. Richard Watt was the organizer, the editor for that special issue. And that was a very important milestone, not only because it helped influence, it's not the only explanation, but it helped another bullet in the ammunition bucket for the UN Declaration. But it started something that Richard Horton spoke about. He said at the launch, oral health has been neglected too long. We need a social movement. Remember the social will, political will, and data. Lancet published a lot of the data, and we're starting to hit on the political will. But we need a social movement. We have to create this globally. This is a hard thing to tackle. But the Lancet wants and is behind the idea of a Lancet Commission on global oral health to jumpstart a social movement. And we are just now, I can report that on, I think a couple weeks ago, or is it 3 weeks ago, that, by the way, is the atlas from the FDI. I'm not, here it is. Global oral health at a tipping point. The Lancet people briefed the WHO head of non-communicable diseases on Thursday, the 5th of December, about the Lancet thing, and they're now on board. So it's happening as we speak. The movement, hopefully, the pieces are starting together. And maybe that's where I should break, because I have a lot more to talk about, but I think this is the exciting point in our history. Globally, that may affect us, each member state, in a different way. And as research only chips away at pieces of it, our research, our ICS 1 and 2, chipped away at it. It's all building, and hope we'll get there. So thank you very much for your attention. Oh, do we have questions? Okay. So you tell me, I don't have this software thing. You tell me.
No,
Oh, it's not on the software.
we're going to
do the traditional route.
Okay, thank you.
Questions from the audience?
Cass.
Lois, a great presentation. Can you reflect on, you mentioned it, we have a system still based very much on the private practice, individual, entrepreneurial dental care system, which is not always in keeping with many of the themes that you mentioned globally. And since you've been at the crux of this, how have you found managing that situation where in some regards enlightenment in a universal, in a global context exceeds the enlightenment that you might have in this country? Can you comment on that?
Thank you, Cass. One of my slides actually deals with this. The question is, we still have mainly a private practice fee-for-service model. I mean, they're true, there are new alternatives, but how do we deal with the entrenched? The turf, the professional turf, as a sociologist we call that professional turf, that wants to stay in place. And maybe some of them won't want to change. Well, a group of us who are in retirement, so to speak, who can't stay away from this subject, it's so interesting and important, gathered together at the invitation of one of our colleagues in Colombia, in Medellin, Colombia, because Colombia is facing this problem of proliferation of dental education institutions and programs. We have that. Brazil has it. India has it. India has, all of a sudden, went from nothing to how many schools? 200? 300, how many? 302, maybe growing. And yet, if you take the metric of population oral health, it's going the opposite direction. Marco Budziak wrote an editorial on JADA. Is dentistry stuck? Every country, Australia, they're all facing this. Proliferation of dental education institutions, throw more dentists at it, but population oral health is going in the wrong direction instead of on the right, This assumption we made in ICS, by the way, the hypotheses were rejected. So, the La Cascada was about, why is this so? Why are we having this problem all over the world? And so we had this La Cascada declaration of why we think. And we brought our experiences together. May not be the full explanation. I mean, each country has a different reason. We have high student debt. The students get out. They have to pay the debt off. They go to the urban center. They start charging a lot of money for aesthetic dentistry, implants, high complex dentistry. So that's one explanation, not the total. How do we select dentists? Who becomes a dentist? Which is one of the questions in 1960s I had to look at too. How do we select them in the first place? Workforce models, and we had an IADR session on inverting the pyramid. So at the bottom, maybe we should have all community health workers, referral up to different levels. Now, how do we deal with it? I think we just raised the visibility. Australia Dental Journal republished La Cascada Declaration. It's an ebook right now. They published the summary, executive summary. Indian Journal of Dental Research did an editorial. Marco did his independently. He didn't even know about La Cascada. And you see these people are starting to question. It's not right. and dental student debt being the highest. So if enough people raise the issue and talk about it, and I wrote a letter to the editor, to Marco, on Marco's thing, to Jada, and I said, just give us a platform to talk about it. Don't change the system yet. Talk about what are the solutions, what are the things that could be done. And the ICS, for example, never assumed that whole systems will be transplanted to the US. Never. But yet some people wanted New Zealand dental nurse to come to and be the US model. We never intended it that way. It was to examine what looks to be effective and use those structural characteristics, because each culture has to do it their own way. You have to build on what is, not change it in total. A revolution isn't going to do it.
Hi, right here.
Oh yeah, sorry.
Thank you so much for that lecture. As a newly joined chief dental officer for one of the states, this is exactly what I would need to take back to our Secretary of Health and the policymakers and all of that. But I will never be able to do it, obviously, the way that you did. So I'm curious if part of your presentations is to talk to completely non-oral health group, and how much more of that are you doing in comparison to the oral health community?
Yeah, I do it as I'm asked to do it. I, for example, went to Baltimore last year. One of the senior community groups asked me to talk. It was a lay audience, and the dentist who asked me, who was a senior himself and was on the planning committee, got very upset at and I thought, oh my God, I really put my foot into it. And recently he apologized, but he was taken back. He said, you shouldn't say that to the public out there. That the more dentists there are, the poorer the oral health. That's not what we want the public to know. And I just read in USA Today newspaper yesterday that dentists are in the top trusted most category for the public. So I'm sure he wouldn't like me to disturb that. So I did learn a lesson, though, of trying to say it a little more diplomatically to that kind of audience. Yeah. But it's something, physicians are saying it, other people about their own. You have to look and say, why is this high cost? And we're so low in the global rankings on infant mortality, on this disease, that disease.
I missed your whole presentation about all the changes that has happened, not only over time with oral health in the US, but globally. Are you doing the presentation? Sorry. I'm curious, like I mentioned, in such a comprehensive presentation, if the non-oral health communities are hearing what's happening globally.
Mary Otto, for example, wrote a book called Teeth. New York Times gave it a wonderful review, and she's been invited a lot of places. She belongs to a group of health journalists, and she's the oral health guru. They all go to her. Mary lives in Georgetown in Washington, and she covered the Diamante driver case. That's how she got into it, with Elijah Cummings and all that. And so she's written a history of oral health in America. And I think it's wonderful, and I give it out. I buy it and give it to. It's a good history, and it's written for the lay audience. And we have to get more health journalists into this, and using digital media. By the way, just as an aside, I also got an email yesterday from Benoit Varin, who said he was sharing what his work agenda was for 2020. And one of the things is digital health. I think, Ellie, you've been involved with Benoit in that area. And that guidelines book is scheduled for release in 2020. He had several other things on the agenda, including a World Global Oral Health Report, which should really be terrific. I can't wait to look at that. This will be first, like the Surgeon General's report, but for the world. FDI has been publishing these atlases, and that's been very useful. There are a lot of holes in the data, but we have what we have. We have to improve the quality of the data. But anyway, that's, I think Mariotto is my go-to person when I need help in that area. She's a very good communicator that way. Good question.
Hello? Okay. Thank you so much, Dr. Cohen. I know there are more questions in the audience, and so please feel free to follow up with Dr. Cohen via email or during a break session. Thank you so much for your presentation.